Hello and welcome everyone to tonight's webinar, the fourth in a series of 6 physiotherapy musculoskeletal webinars brought to you by Capital Health Network and a multidisciplinary team of hardworking health experts, including physiotherapists, psychologists, specialist pain and sports physicians, and orthopaedic surgeons. Before we get started, I would first like to acknowledge the traditional custodians of the land we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending this evening's event. Their land was and has never been ceded. Tonight's webinar focuses on bone stress injuries. I'm Michaela DeLeva, physiotherapist and Quality Improvement Project Officer at Capital Health Network. Also with me tonight is Sam Jeffery, physiotherapist, Erica Stevens, dietitian, and of course, Kanal Mahiti, the events lead at Capital Health Network. Before we get things started, I'm just going to run through a little bit of housekeeping. All participants in the Zoom this evening have been muted, so please address any questions in the Q&A section of the Zoom meeting tonight, not in the chat box of the side panel of your Zoom window. We will have time for a Q&A session after both Sam and Erica have presented, and the presentation itself will be uploaded to the Capital Health Network YouTube page, which you're welcome to share amongst your networks. In regards to CPD, please fill in the post-event evaluation survey that CHN will email out. Then you will be emailed your certificate of attendance for the event. Please feel free to self-report 1.5 hours of educational activities to your CPD home after attending tonight's event. Before we start, I'd also like to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including musculoskeletal injuries. To access the website, the login is together and the password is for health, all one word. Health Pathways are a reliable source of up-to-date clinical and referral information that is localized to the Canberra region. Your feedback is invaluable to keep the pathways updated and reflective of our local health environment, so we encourage you to find the feedback tab at the bottom of every pathway and utilize it if you think something needs to be updated. I'd now like to introduce our first speaker of the evening, Sam Jeffery. Sam is a physiotherapist at Capital Clinic Physiotherapy City West. He has a special interest in foot and ankle conditions and has undertaken further training in the field, including development courses and time observing foot and ankle surgeries. Over 1/3 of his patient load comprises foot and ankle injuries and complaints. Sam believes that the foot and ankle offer complex challenges for patients and healthcare providers, and he hopes to provide a high level of diagnostic and rehabilitation skills to this niche area of physiotherapy. Please join me in welcoming Sam.
Thank you for that. Yeah, so as Michaela said, my name's Sam and I'm a physio at Capital Clinic. When I first, I think, sent that bio over, I'm probably more like 50-50 now on foot and ankle patients versus other patients, which I'm going to speak a little bit about tonight. As you can see, I've labeled mine as lower limb bone stress injuries. So I'll speak briefly about a couple of different bone stress areas, but most particularly we're going to focus on two. And then one of those will tie in with what Erica will speak about afterwards as we managed a patient together. And that will kind of at least bring a through line for both mine and Erica's presentations. So bone stress injuries, how do they occur and what are the risk factors? So stress injuries reflect a mismatch between the bone strength and the chronic load placed on the bone. So that can be either due to fatigue, which is abnormal stress on normal bone, or insufficiency, which is normal stress on abnormal bone. So typically the way we see this in that first case is it's someone who's elevated their activity, whether that be running, jumping, usually high impact activities. So they're getting that kind of increased level of abnormal stress on a normal bone, which can end up in a stress reaction or can progress to a stress fracture. Or in terms of insufficiency, we're talking more about normal stress, which might just be normal walking loads or jumping, hopping, body balance, that type of thing, but the bone is abnormal. And we're looking at osteoporosis there or osteoporotic bone. So usually when someone presents to clinic and their history is sounding in one of those ways, we will have a high suspicion of bone stress, or we could have a high suspicion of bone stress. Some of the risk factors we're also going to be looking out for inadequate footwear or a change of footwear, poor nutritional status, excessive training regime, or the female triad, which is irregular menses, eating disorders, and decreased bone mineral density. And I'm not too sure, but potentially Erica will go into that a little bit. I will touch on some of it, but it's not exactly my area of specialty. The one thing I will say around vitamin D, and again, Erica might go into this, but vitamin D levels become an important factor in the diagnosis and the treatment of stress fractures. We found that insufficient vitamin D limits the intestinal absorption of calcium, which leads to upregulation of the parathyroid hormone. This causes increased bone resorption, which can result in fracture and impaired bone healing. Vitamin D also functions to upregulate the transcription of genes involved in neovascularization of the fracture healing site. So obviously that's a big mouthful, but what we tend to find if we have a patient that comes in and we're suspecting bone stress and potentially we say, okay, we need to get a few things checked medically. I might write a letter to the patient's GP saying, this is my suspicion. Is it possible we can get blood tests looking at vitamin D, calcium, other inflammatory markers potentially? And often we'll find that those vitamin D levels come back low, and potentially that's as a result of the fracture or it's happened prior to the fracture. It's a little bit hard to say depending on where someone is. But it's just one of those things that helps tie in that stress injuries and stress fractures are multidisciplinary, and we usually, for really good management, need GP, physio, potentially dietitian, sports doctor, surgeon, all kind of linked in on what's going on, because there's different stages to where everyone is going to add something to that patient's treatment. But I just thought I'd touch on that quickly. I think Erica might be able to go on with that much better than I could later on. So the prevalence, they are quite high prevalence, but in the lower leg and the foot, we're looking at 75% of them happening there. And when we say stress injuries, we don't exactly mean progressing all the way to stress fracture, but it is a continuum, and I'll go through a little bit about that in the lead up. The ones I'll focus on today are a navicular stress injury or stress fracture and a tibial stress injury. That being because the navicular is a high risk bone, so there's some different challenges to the management in terms of the navicular, and the tibia does have a high risk area, but we'll talk, the case study is more of a low risk area for the tibia. So the navicular stress fracture is 25% of all foot stress fractures, which is quite high for such a tricky injury. And it's most common in young males, short distance runners, and basketball. And a lot of that's the agility, change of direction, short spurts, quite high intensity exercise. I've listed a couple other ones here, but we're mainly going to focus on navicular and tibia. Medial cuneiform is quite rare, 2.7%, most common in young females. Metatarsal stress fractures are 9%. That's 9% of all stress fractures, not just 9% of lower limb. And young females are the most common. And the third met fracture is known as the dancer's fracture, which people may or may not have heard about. And then tibial stress injuries, so not fracture, but injuries, account for 49% of all bone stress injuries. So basically 50%, which is really quite high. It's why I've included it in this presentation, and we see it all the time, whether that be on the continuum of something like shin splints or medial tibial stress syndrome, all the way up to stress fracture. But we see quite a lot of it, and the management can be poor, but I'll hopefully go over a little bit on how we can make sure we're doing the best job with these particular patients. And that's most common in runners, but in particular young female runners. So what do they look like on imaging, and what's the gold standard? I'm by no means great at reading images on MRI, but I do try my best. I think it's quite a good exercise. I try not to read the report, have a look at the images, come up with what I think it is based on trying to do a little bit of self-learning and then go from there. Typically, I could be wrong, which is good why a radiographer is going to write a report, but it's a good way, I think, to try and understand it better, know what I'm looking for, and then I can better educate a patient or upskill myself in that. MRI is the gold standard because it's the best at detecting that bony edema, which we'll see in a stress reaction, but it might not necessarily be present on X-ray when there isn't a fracture. And then on CT, you might not get the fracture line. So MRI is the best for this because we'll get all of that. And we have a good grading system, which can help us kind of put people in buckets in terms of how far on that stress continuum they are. And then the added benefit is no radiation exposure with MRI. Obviously, one of the drawbacks of that is MRIs are expensive for patients. So depending on who it is, it's just really about educating why it's necessary. If I have a really high suspicion of a stress injury, I will typically say like, yes, and maybe the person doesn't have a lot of money, but I'll say, look, like this could drastically change our treatment, which is why I would do something like an MRI versus an X-ray. Whereas if I'm not thinking that they have a stress injury or a particularly bad stress injury, you might forego it depending on where they are. So what do they look like? So based on the Fredrickson grading system, we go from grade 0 to grade 4B, grade 0 being normal, grade 1 showing some periosteal edema, but no bone marrow abnormalities. Grade 2 has that edema plus the bone marrow abnormalities. Then grade 3 goes from that mild bone marrow to extensive bone marrow edema, which we can kind of see in these pictures going along. And then grade 4A and grade 4B is when we're really getting towards fracture. So grade 4A has multiple focal areas of intercortical stress or signal changes, and then grade 4B has the fracture line. Again, that may not necessarily show up on something like a CT, and that's why MRI is so good. Or if someone's already progressed to the stage of grade 4B, that might show up on X-ray. But really, we want to be picking these up much sooner than grade 4B or grade 4A, which should normally be possible when we're talking about abnormal stress on a normal bone, maybe not so much when we're talking about normal stress on an abnormal bone with our osteoporotic patients. So in terms of radiography, again, I'm not sure how skilled people are in this, but a way that helps me read MRI is T1, Terminator 1, Arnold is bad, therefore water is dark, and T2, Arnold is good, therefore water is light. Shouldn't really be spoiling a movie that's 20 years old, but it's helpful to have that in my mind. I always think of it when I look at MRIs, when I'm looking at T1 and T2 weighted images. Again, I'm certainly not the best at it, but it does help me look at it. So that's a bit of a lead into this. So I've kind of tried to get the previous images where we're showing those changes as it goes from grade 0 to grade 4B versus what it looks like when we're looking at T1 weighted images, and then got an example of that kind of water is white and water is dark on these two images in A and B. Again, how much people take away from this, I'm not too sure. Like I definitely rely on reports, and I definitely will talk to a sports doctor or a surgeon if it needs that extra opinion. But I just try to look at these to get better at them, and getting there slowly. So low risk versus high risk bones. So high risk, there are quite a few. Calcaneus, fifth met, second through fourth met necks, sesamoid, tailor neck, tarsonavicular, anterior tibial cortex, and medial malleolus. Now, I definitely don't just have them off the top of my head, and when someone is pointing to their met neck, I don't think, oh, that's high risk straight away. I certainly have to go back and look at to make sure I'm dealing with it appropriately in high risk versus low risk. But in particular, the navicular, the fifth met, and the anterior tibial cortex, I would say, are the big three high risk. Fifth met being that Jones fracture. Navicular is, and I'll go into it in depth, why it's such a problem shortly. And then I'll also talk about the anterior tibial cortex. But on those other ones, if that's where I'm thinking the injury is, I'll always go back and check. And the reason they're high risk is they have a region of maximal tensile load in a zone of diminished blood flow that is vulnerable to stress injury with suboptimal healing. So basically, bones that don't heal very well. So in particular, the navicular again, which I'll go into in depth. And then these high-risk bones, typically you want to be managed you want to manage in consultation with a sports doctor or orthopedic surgeon, just because there is that higher level of care required. There's more that can go wrong. And the problem with poor management in a high risk bone is like sinister and significant. So we want to make sure, even if the sports doctor or orthopedic surgeon says, no, this can be managed conservatively, you're doing the right things, like I always get the opinion if it's in one of these areas. And then low risk, posterior medial tibial shaft, fibula, and second to fourth metatarsal shafts. So again, these are unlikely to require specialty consultation, and they typically respond well to conservative management. And that might be the case for high risk as well, but it's always worth getting that opinion just in case. And I've had multiple navicular stress injuries that haven't quite gone to fracture, that I've said, no, we just need to get the opinion. Let's go sports doc or orthopedic surgeon, who they've then sent back and said, just treat as normal. But again, really worth doing it if that's where we're thinking someone is. So how do they present? So there's a lot that can bear out in a history, but stress injuries tend to have the same hallmarks. And I think if the shoe fits, like it is good to have a high suspicion. And typically, if someone does start giving me their story on why they're presenting with midfoot pain with no particular mechanical reason, like I'll already have have bells going off. Okay, let's make sure we're really making sure that we're not dealing with some sort of stress injury in the midfoot, particularly thinking of the navicular. Because if I have high suspicion when a patient starts talking through the subjective, I can really make sure my questions are going to answer everything I need to answer. And I'll spend a lot of time in that subjective asking a lot of questions, which I potentially wouldn't normally ask. Whereas if someone comes in and they go, I rolled my ankle and I have pain on the outside of my ankle, and they're pointing to their ligaments, I'm like, well, that makes a lot of sense. I don't have to ask diet questions when you had an acute lateral ankle sprain. But when there's that, well, there's not a mechanical sign to the patient, but that we might be able to pick it up based on their history, that's when I'll really get into it. So let's use the navicular as a bit of as a proxy for anywhere where people can get tibial stress. So typically they present with poorly localized tenderness around the side of the bone, which is basically midfoot tenderness and pain. Sometimes people will be like, it's right here, and they'll point to it, but often they'll kind of grab their midfoot, or they'll kind of put their fingers in an arch around their midfoot to describe where their pain is. Again, the subjective is really, really important. It's where we're going to get so much of the information that will guide our objective and potentially guide if we're sending people on for further opinions, imaging, etc. But what we usually see is that chronic load. Again, unless there's a case where the person is osteoporotic or they don't know they're osteoporotic, but that seems like a likelihood, then there may not be that chronic load. The other thing with chronic load, which is tricky, is there's more and more evidence now to suggest that chronic load isn't just in the months leading up, it can be years and years in advance. Only in probably the last 6 to 12 months, I've been noticing how much that can be the case. For instance, marathon runners or long distance runners who've been running for 40 years, they haven't changed their activity that much, but then they come in looking like something is a stress injury. Like, well, I haven't really trained anything. I'm really careful with my training. But if we look back on it as a whole, the entirety of their load is just massive. And it doesn't matter if it hasn't changed that much in the lead up. The whole lifetime load can have an effect on a bone, particularly an aging bone. So I think lifetime load is a good thing to talk about as well. But in particular, those months leading up can usually yield the results for us. Looking for those risk factors. So poor nutritional status, the female triad, and inadequate footwear. So poor nutritional status can mean a lot of things. And again, Eric is going to be much better equipped to talk about that. But a few questions I might typically ask a patient, things like, do they eat meat? And if they don't, how long have they not been? Do they eat any seafood? Like, just trying to get to see like what their iron intake's like, what their calcium intake's like, if they're not eating any dairy or drinking any dairy. And then usually how long that's been going on for as well. If it seems like it's part of the issue or part of the problem, particularly in the athletic population, like referring on to someone like Erica is what I would do and say, I don't know, can you tell me what's going on here, because you're much better at this. The female triad, so Again, coming from a physio, like the questions can sometimes seem really personal. So I'm always explaining why I'm asking the questions, because if I'm asking about irregular menses when a patient's just coming with midfoot pain, they might be like, I really don't know why you're asking that. So making sure you have rapport with the patient, particularly for myself, is important. Particularly as a male asking potentially a young female about if they're having irregular menses. I basically say when we're thinking of a stress injury, there are multiple factors we need to consider, and this is one of them. And people are usually pretty good as long as you don't just kind of fire off a question out of nowhere. And then inadequate footwear. And I think with footwear in particular, I think in the past, I probably didn't treat it as important as it is. Not that I didn't think it was important, but it's really, really important. I'm seeing more and more people that come in with what's looking like a stress injury after a change in footwear or after wearing footwear that's not appropriate anymore. If they've run, I don't know, 10,000 kilometers in it or something, and all the shoes worn apart and they're still running those kilometers, like I would consider that to be a load change because they're now getting more ground reaction forces from poor footwear, or they've changed footwear from a soft shoe to a rigid shoe, or a rigid shoe to a soft shoe. Just a lot of questions in particular that I will have in mind for this type of a patient that I wouldn't typically ask another patient. Previous history of fractures and stress fractures, really commonly reported and just a good one to flag and super easy to flag. If someone's popping up with multiple stress injuries, the question's why, which would be more of a reason to get a medical workup, even though we always want to be getting a medical workup on stress injuries. I remember some sports doctors that presented to us and basically said, if you're thinking stress injury, stress fracture, like there needs to be bloods done. We need to know what's going on because typically healthy bones, even though there is an increase in workload, shouldn't just come down with bone stress or a stress fracture. We want to make sure there's nothing else going on. And then in the case of navicular stress or stress fracture, studies have shown that 8 in 10 will have maximal tenderness over the end spot, which is very specific for the navicular in particular. But I think it's a good thing to say and a good thing to tell people because it's a really easy test. And if you are suspecting something like a navicular stress injury or stress fracture, knowing where the end spot is and going, boom, is that your pain? And the person goes, yeah, that's definitely my pain, is actually diagnostic and can help with imaging or who you want to refer on to next. And I'll go into that shortly. So the navicular, I've talked about it a couple of times, but the reason I'm going to talk about it is it's so complex in rehabilitation. It can be a complex pickup in terms of the pain. People might not present until it's too late or present after months of pain and they become really difficult to manage. But one thing I found that kind of described why the navicular is so difficult, I think is helpful. Again, it's a mouthful, but the navicular serves as the structural link between the hindfoot and the midfoot. It has limited blood supply, which results frequently in non-union when not managed correctly and has long return to sport times. Its anatomy means it endures all the lateral stress caused by the midfoot joints, as well as shear from the hindfoot, and then medial stress from the tibialis posterior tendon that attaches onto the medial side. So the navicular is just getting pulled all ways. We're getting axial loading, shear loading, all of this load on a bone that then has poor blood supply and doesn't heal very well, which is why people potentially have heard horror stories of navicular injuries because it's so important in that structure of our midfoot, yet it endures so much and then it doesn't heal very well. So the reason I'm put this into the presentation, we'll talk about it quite a bit, is because picking these up can be life-saving for people because when managed incorrectly, these go really, really wrong. And thankfully, so far, I haven't seen many go too wrong, but yeah, they can be really quite bad. As I said before, so the end spot. So here's a couple images which hopefully help. So we're looking medial side of the foot. The end spot is basically like a 5 cent piece right in between where the tib tendon comes down into our medial longitudinal arch and our extensor hallucis longus comes over our big toe. So then on the person's foot where we've drawn that in, that X is right where it is, and it's really like a 5 to 10 cent piece. It's quite a localized area. It's a really good one to know because in the management, so it helps diagnostically, but let's say, for instance, the history makes sense. Let's say it's a young male basketball player, it all kind of adds up, and you push on that spot and they go, that's an 8 out of 10. Like that's definitely my pain. You get your imaging, let's say there's a navicular stress or a navicular stress fracture. It actually then becomes a reassessment tool for us. So I'll go into the loading and how we manage a navicular stress injury, but we use the end spot as a test to see if someone's progressing through their weight bearing okay, and whether someone needs to go back into a boot or back into a non-weight bearing boot. So it's quite good diagnostically and quite good as a reassessment tool. So it's a good one to have in the bag. Some differential diagnoses. So obviously we don't want to be sending all midfoot pain patients off for MRIs because we think there might be navicular stress. We want to consider what else there could be there, and having like really nice specialized skills to rule in and rule out the differentials is important. So tibialis posterior tendinopathy is a big one because that tendon attaches right on that medial tubercle of the navicular. Being able to determine if it's navicular pain or insertional tendinopathy pain at the navicular is tricky, but being really good with our patient helps that, knowing when we're on the navicular versus on the insertion of that tendon. And then again, obviously, if the subjective folds into that. Tibialis anterior tendinopathy. So again, that end spot is a 5 cent piece that runs between those tendons. It's pretty easy to be half a thumb width across and pressing on someone's tib tendon. And if we're just compressing their tendon and going, oh yeah, I heard about navicular stress, that's navicular stress, that's really easy to get wrong. So I spend quite a long time with palpation and then obviously with the subjective history to make sure to make sure I believe this is true stress or is it tendinopathy, because obviously the treatment pathways are quite different and we don't want to be sending people for unnecessary imaging. A midfoot sprain, like a Liz Frank. Liz Frank injury often present with diffuse midfoot pain as well. Now, ideally or hopefully the subjective is going, well, that's like that happened acutely, whereas we think the stress injuries kind of have that chronic load, and we can usually get a bit of a bearing out of that in the subjective. Chronic deltoid sprain, again, just proximity to the navicular with the deltoid, and seeing if that is something we think is potentially a diagnosis is important, and we can test those ligaments quite well and see if we think that is a problem. And then medial midfoot instability, which is really quite tricky, probably in the lower end of differentials. But if, for instance, someone came back and we did send for an MRI because it all looked like that and it wasn't, and everything else had been cleared, we could be looking at something like a medial midfoot instability, which I have a battery of tests I do for it, but reasonably rare and won't be most of the patients we see. So management. So there's operative and non-operative. So again, high risk bone. So I'm usually getting a higher medical opinion than mine, just to make sure that either I'm on the right track or that if they need more than what I can potentially give them with the non-operative treatment, that they're getting that. So for grade 1s to 3 stress, and can be done for a fracture, but we'll go into that soon. We're talking 5 to 8 months return to sport, which is really long. So really expectation setting and telling the patient early is important, because it's a long time, because usually depending on the level of stress, they can be 4 to 6 weeks non-weight bearing in a boot, followed by 1 to 6 weeks partial weight bearing in a boot. So potentially up to 3 months in a boot, followed by 12 weeks of gradual loading back into sport. So we're talking 6 months just there. And that's if everything goes right, which with navicular doesn't usually all go right. And if they get tenderness on their end spot when we're coming out of that non-weight bearing boot and they're into partial weight bearing and then they're tender, then we have to put them back into non-weight bearing. So this can definitely go longer, which is why we have that 5 to 8 month, that 3-month window that we tell people, because typically, as long as unless they manage really well, which I hope we will be, is they can go a little bit eerie. As I said, so we check that end spot fortnightly. I probably don't quite check it fortnightly, maybe more like monthly for these patients. I don't really want to just be poking on a bone that's causing someone pain. But if I am upgrading their weight bearing status, it needs to be checked to make sure that they're handling that weight bearing status upgrade. And then rehab, physio-led, is typically focusing on returning dorsiflexion, returning calf strength, foot intrinsics, plyometrics, and then sport-related movements. Again, if this person's been 3 months in a boot and half of that time is non-weight bearing, we're likely dealing with wastage at the calf, a lot of muscle loss, and we really want to make sure that we have good period of time to build those up. 5 to 8 month return to sport is a window. That doesn't mean that when someone gets to 8 months, even if they're not as strong as we want them to be, they just return to sport. We want to make sure we're really diligently testing these people. Because if we send someone back out with a poorly healed navicular and it goes again, it's not going to go very well. Then operative. So this is often recommended for elite athletes or people with really high physical demands, and it's typically just shorter return to sport. And that's because there is like a certainty on the healing of the bone. We stabilize the area. We know it should heal well. The boot period is similar, non-weight bearing 6 weeks, partial weight bearing 6 weeks, and then gradual loading for 6 to 12 weeks. So we're typically back in that 4 to 6 month range. There's still obviously challenges, but the evidence suggests that there are less failure rates with surgery. So here's the operative versus non-operative. Basically 96% successful outcomes with operative versus 78 successful non-operative. 78 sounds good, but like 22% unsuccessful. It's pretty high, 1 in 5. So we want to make sure that when we're going through this decision with a patient or we're speaking to the sports doctor or surgeon, that everyone's aware of what can happen. We want to make sure the patient knows that the boot wearing is like really specific. They can't just be like, oh, I wanted to get my boot off today and I walked to the kitchen. Like it really needs to be quite tightly defined, because that's why we're probably seeing these high failure rates and I know with patients I deal with is, unless I'm really, really specific on what they're supposed to be doing with their boot, they might consider partial weight bearing to be, when I'm outside of the house, I'm using my crutches, but when I'm in the house, I take the boot off and I walk to the toilet and things. And that's not really, we want really nice defined strategies around the boot. And then, one study showed 20 refractures of 78 managed non-operative versus 1 refracture of 78 operative. So obviously really good for the operative group, but that's quite high in the non-operative. And again, it just speaks to how difficult this bone is and the management of this bone. Cool. A bit of an easier one, but much more common. So tibial stress injuries. So highest prevalence of bone stress injuries has been found to be at the tibia with 49%, so effectively half. This is tibial stress injuries, so not all tibial fractures. And medial tibial stress syndrome, aka shin splints, falls under this, which is probably accounting for quite a lot of this, but still really, really common. And I would say I see, I don't know, 5 to 10 every month or two. Like there's quite a lot that comes through the clinic. And we have to consider medial tibial stress syndrome to be on the continuum of tibial stress fractures at the lower end, of course, but on that continuum and treated as so. So some differential diagnoses. So MTSS, aka shin splints, exertional compartment syndrome, tibialis posterior tendinopathy, and popliteal artery entrapment. So exertional compartment syndrome is a tricky one, but one we want to be considering depending on the patient's symptoms. Again, like I'll sound like a broken record, but coming back to the subjective can be really helpful on this. Tibialis posterior tendinopathy is a differential for both navicular and tibia, because at the navicular, we're talking about the attachment of the tendon, whereas at the tibia, if we're considering it, we're thinking more up towards the muscle belly or in that kind of more proximal part of the tendon. And then popliteal artery entrapment, which I have not seen much of at all. So management, it's a little bit different. So the most common management is non-operative, and it's usually really quite successful. And it ranges from activity modification, which could be as much as immobilization depending on pain levels, to low impact activities, to reduced running loads, all the way up the chain. And then looking at using pain as a good guide for this, as well as a navicular, but we have to be really, really quite careful on the navicular. Well, tibia too, but extremely careful on the navicular, but looking at reducing activities if pain is elevating through our progressions. And then rehab, again, similar to the navicular, but really need to focus on calf strength, entire leg strength, plyometrics, and guided return to activities. The one thing I would say in terms of the ones I've managed and are managing, particularly if they're second opinion ones that have been sent to me, is there is just a distinct lack of plyometrics in people's rehab of stress injuries. We seem to think that we can rest people and then give them slow calf raises or something, and then they can just return to running, when the difference between a slow calf raise and running is so significant that we want to make sure we're bridging that gap with nice progressive plyometrics. I'll go through a case study shortly, but there's quite a bit of plyometrics in it, and it took a long time to make sure that we were happy with how she was going to return to running. In terms of operative, there's potentially an intramedullary tibial nail required if there's the dreaded black line. So the dreaded black line is a subtle radiological sign of a unique type of high-risk stress fracture, which is in the anterior tibial cortex, which is one of those I talked about earlier in terms of one of the higher risk parts of the tibia. So it's not all low risk, and it's, as it sounds, it's a black line in that area on an MRI, and much like the navicular, we're talking kind of 4 to 6 plus month return to activities because we've had that surgery and the need for the stabilization. And rehab is the same once we kind of have gone through the protocols for rehab. And I think, again, like poor management is something we see quite a lot with shin splints, because shin splints doesn't sound as bad as stress reaction. Or if I told someone they had shin splints versus I told someone they had a grade 2 Fredrickson stress reaction of their posterior tibia, one sounds much worse than the other, and our wording can be really important. Shin splints, people go, oh, I know, I've had shin splints. My friends had shin splints. Shin splints is shin splints. But it's really on that continuum of a stress injury. And if we're not trying to catastrophize, but we want to make sure people know that it's serious, or at least partially so. And if not treated properly, it can get really quite bad. Like it can get as bad as something like needing this surgery, which can be 4 to 6 months off activities. So I've found in particular with wording, again, not wanting to catastrophize, but just make sure people are familiar with the reality or the expectations of what's going on, can be really helpful, can really help with buy-in. You know, we're asking people to do a lot. We're asking people to potentially be in a boot for 3 months. So we want to give nice context as to why that is, why that's such an important bone. I think education and advice around why these take so long and what's at stake can be really helpful to make sure people are staying compliant with weight bearing and non-weight bearing instructions, or how much running they can do, etc. And again, like we'll go through that on the case study, but making sure we're really, really specific with people is so important, because if I say we can return to a little bit of running and maybe up to 10 minutes jogging, every single runner that has not been able to run for months is going to do that maximal amount straight away. So I always make sure I'm like, nope, we're doing exactly this. And once we've achieved that, we can do this. And I really set it out for patients. And I found that to be really quite successful. So again, operative versus non-operative. So yep, high return to sport rates. Similar to the navicular, there are more failure rates in the non-operative group, but it's lower. So it's 12.5% versus 20% of the navicular, which is quite a bit lower. But still, you know, telling someone that 10 in 100 or 12 in 100 people might have a fail is still a big number. So just making sure we're being really specific with people and then making sure our management's good is the key. Cool. So case study. So this patient is an early 20s female who presented to physio with left shin pain in the lead up for training for a marathon. So immediately, ding, 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 young female runner, obviously more training coming up into a marathon with shin pain. Like almost immediately, like, okay, it's stress injury until it's not stress injury. So described an increase in training loads. There was a change of shoes, and there was increasing shin pain. So it's alarm bells galore for me. So I asked some more kind of probing questions, and history was bearing out some flags for REDS, relative energy deficiency syndrome, which again falls into that female athletic triad. And there was a sports dietitian, just a great sports dietitian, Erica Stevens, who also had the same suspicion. So that was good. And then there was also a report of shin splints that resolved in the last 12 months. So in terms of what I said with risk factors at the start, we're ticking every single box, including previous history of a stress injury. So really quite quickly, within 5 minutes of talking to this patient, this is a stress injury until it's not. And I'm trying to prove that it is or it isn't based on what I do next. So in terms of the objective, so tender over the shin, but the highest intensity of the tenderness was less than 2 centimeters. So typically with medial tibial stress syndrome, we're getting that kind of larger range of tenderness, usually over 5 centimeters. And this patient was tender over 5 centimeters, but the highest intensity of it was like this little 2 centimeter area. So that localized tenderness, again, is just more reason for me to think we need to explore this further. We had pain provocation with repetitive double leg jumps and single leg hops straight away. And I ruled out the differential diagnoses with palpation, resisted tests for the tendons, etc. And this was just as easy as it comes for me in terms of diagnosis of a stress injury. So we sent for an MRI, and it confirmed grade 2 Frederickson stress response on the left and also the right. So not really reporting right shin pain. MRI picked up both, which is really interesting. It again goes to show that sometimes these don't present as sore until much later in the piece. So I can say as much as I want that we're trying to pick them up early, but sometimes people won't get pain until later. And we just happened to pick up that the other shin was also having a stress reaction. So that was handy, but confirmation of that grade 2 Frederickson stress. Cool. So management. So we discussed sports doctor referral because I always like to, even in a low risk area of the bone, because I just think having that medical opinion is really important. But we already had an endocrinologist, a sports dietitian, the GP, and myself engaged, and the patient was happy. It was like, I feel like I've got, she said basically to me, I feel like I've got everything I need. Everyone's on top of it. We can do this. I don't really want another appointment, another movement through there. And with grade 2 stress in a low risk area, I was okay with that. If it wasn't the case, I would be really pushing, saying, no, we actually do need this, but we didn't in this case. Again, we were able to get the nutrition sorted by an amazing sports dietitian in Erica, which allowed me to focus entirely on deloading, reloading, make sure the patient was doing exactly what I needed them to do. The way it ended up, again, this wasn't necessarily from the outset. The expectation was 10 weeks off running, but we ended up 10 weeks off running. There was 1 month between the last run and the MRI confirmation. So we weren't running then as we expected that, but we didn't know how big the stress was. And there was 6 weeks of building from confirmation of the MRI, which ended up being 10 weeks total. Management. So from my end with rehab, consisted of progressive weight-bearing exercises, focusing on challenging the tibia with axial, torsional, and bending forces. So basically what I mean by that is while we're not running, while we're not getting that repetitive ground reaction force, we could safely and progressively challenge both sides, both shins, to work through forces moving laterally, up and down, with plyometrics, a lot of different ways of putting this this tibia and this bone through stress so it can adapt and become stronger, adapt and become stronger. So when we do eventually go back to running, we don't just have 10 weeks of deloading where we now have a weaker bone and then we go boom, straight back up into running. We want to try and really curve that dip and then slow increase into running, which is why I spend quite a lot of time on plyometrics, ranging from really low force plyometrics to high force plyometrics before getting my patients to run. And once tenderness had reduced and was approaching being able to trial running, we did that plyometric training, which was quite extensive, and like I'm happy to answer questions about it at the end, but in terms of time, I might just rip through these last few. So the return to running plan, again, I was really, really specific with this patient, which I think was needed and necessary, but we started off, someone was training for a marathon, so quite fit, quite strong, has done a lot of running in their life. This can be quite hard for them, but we went 2 minutes jog, 2 minutes walk, 2 minutes jog, 2 minutes walk, 2 minutes jog. So 6 minutes of jogging interspersed with walking. And that's the entire session. That's how we started off after all of this loading. The rule that I had was we had to be able to get through that pain-free. Then we had to be able to get through it pain-free again before we were able to progress to the next one. So I wanted 2 successful sessions before I moved forward. Then we went 2, 4, 2, 4, 2. So we've had an extra 4 minutes of running across 14 minutes. Again, same rule, then 1, 5, 1, 5, 1, and then a 10 to 12 minute straight jog, not run, jog. So we're still talking quite low. And a big thing that I was making sure of with this patient is that load is volume times intensity, which is kilometers or time times speed and elevation. So often being really specific that like, yes, this is the time. That doesn't mean you can just run it faster, because I'm not letting you run for a long time, because that's still going to peak your load or peak your work rate. So I said, like, when we talk about going 2, 2, 2, 2, 2, 2, 4, 2, 4, 2, 1, 5, 1, 5, 1, the pace stays the same. We don't have any elevation. We're keeping everything a constant. We're just slowly adding that volume. The elevation and the intensity can come later, but that needs to be done really specifically. Again, like buy-in and expectation setting is really important because we're asking someone to start from such a low period when they were previously so fit in this particular case study. So in terms of how it went, we basically had first pain mid-January, first appointment late January. Loading began quite quickly, and we can load quite quickly when we know that it's a low risk area and we're using pain as a guide. Then we had progressive plyometrics for, I think it was 5 weeks, 20th of Feb to 25th of March, which is a long time to be doing that type of thing, but it's really necessary. And honestly, we probably could have done longer. I always try and do it as long as I can. We began running in March, and it took a couple of months before we could run 3 to 3.5 Ks at a time. So we had basically 4 months of physio guided return to running, and we were not where we were prior to the stress injury in terms of load, nor should we be, because it needed to be progressive. And I like to illustrate this just to show people how slow it can be or should be. Not all of them are like this, but we think on this particular patient, there was a lot of flags, there was a lot of things going on. This wasn't just a fit 30-year-old who just did a bit more running that week, and then they got a stress reaction and they had no previous medical issues. There were multiple things that kind of led to this stress injury, so we had to really be careful with it. Thanks.
Thanks, Sam, for an excellent presentation there. In the interest of time, I'm going to jump straight into introducing our second speaker of the night, which is Erica Stevens. Erica is an accredited sports dietitian, accredited practicing dietitian, and credentialed eating disorder clinician working in private practice in Canberra. Her main areas of work are adolescent athletes, relative energy deficiency in sport, and disordered eating/eating disorders. She currently consults to Cricket ACT and the Canberra Capitals, and has previously consulted to the ACT Academy of Sport and the AIS Centre of Excellence boxing program. Please join me in welcoming Erica.
Thank you, Michaela. I shall share my screen. So yeah, thank you for having me tonight. Hopefully I can progress all the nice little nuggets of mention of nutrition from Sam. I do have a strong interest in bone stress and nutrition for bone stress by nature of working in high performance sports. So with cricket, we have a high risk of bone stress in our fast bowlers, in their back and in their landing shin. And then obviously, as Sam mentioned, with basketball, that navicular stress fracture is something we want to avoid. So I spend a lot of time in high performance sport on the prevention side because we all know that sport is a business of winning, and the best way that we can be in a position to win is if all of our athletes are available to play, and bone stress just takes so long to come back from. So we really focus on prevention in pre-season, and the things that I'll talk about tonight regarding nutrition are the things I focus on when I do my pre-season nutrition screenings with those athletes. But I also work in private practice, and that's where I see someone after a bone stress typically. So they might be referred by GP or sports physician or physio or self-refer sometimes. And so I'm in the business there of reducing their risk of a further bone stress injury. So figuring out where there were some nutrition gaps and making sure we plug those and move forward in a really healthy way from a nutrition perspective. So that's sort of my background, I guess, with bone stress. So these are sort of the three main themes I've picked out for tonight. So just a really quick mention of bone formation versus bone breakdown and the key nutrition part of the equation of that, and then focusing on the things we have the most evidence for, which is energy/calories/kilojoules, depending on where you live in the world, which word you pick to describe that. and the syndrome that we now call relative energy deficiency in sport, which has progressed from the female athlete triad in terms of our understanding that it's affecting all systems in the body, not just the few that we first thought in terms of menstrual function and bone. And then calcium, vitamin D are two main nutrients implicated in bone health that have the most evidence surrounding them. And I'll just touch on some of the other nutrients that we want to just tick off as well when it comes to bone. And then spend a bit of time on the populations we really need to keep an eye on and that sort of might pop up red flags for us when it comes to people that are going to be at high risk of low energy intake or low calcium or have an issue with their vitamin D intake. So this is where I spend a lot of my time as a dietitian in the world of energy balance, because a calorie deficit or inadequate energy intake from food influences both sides of the equation with bone in terms of increasing the breakdown of bone, but also decreasing the formation of bone. So it's a bit of a double whammy when we have inadequate energy. And that's sort of where I'll start and where I'll delve into and where we've sort of landed, I guess, with the syndrome called REDS. But of course, there are some other nutrients that we need to keep on top of. It's not just energy. So if we have adequate energy and a vitamin D deficiency, we've still got a problem. And if we have adequate energy and poor calcium intake, we might still have a problem. And then we have a range of other micronutrients that might be involved, as well as protein, the macronutrient. These tend to be less of concern for me, but I would still look for them, particularly in various populations like vegans. But I don't tend to see people that underconsume protein. That's quite unusual. It more so happens in women than men, just by nature of food preference that I've just noticed over the years, but quite unusual if people are eating from all our food groups in Australia, that we would have these micronutrient deficiencies, but I'm certainly not disregarding them as I go through someone's diet history. So basically, we're in a position where we can have, like I said, enough calcium, enough vitamin D, but if we don't overall eat enough energy, then bone breakdown and bone rebuild will not be equal. And over time, we get bone that is compromised and becomes stressed and susceptible to fracture. And how we determine adequate energy availability for the body and therefore bone is actually really, really difficult in practice. And we don't actually have a really great precise method to do this. So there's a lot of error involved, and we really just want to make sure we're in the ballpark as opposed to being perfect with this. But essentially, what we know as being energy availability is if someone has 35 to 45 calories per kilogram of their fat-free mass available to them after the cost has been taken into account of whatever exercise they've done that day. So purposeful exercise is what we're talking about here. So they've gone for a run, a long walk, they've played basketball, whatever it is that they've done. So I'll delve into that equation in the next slide in a bit more detail and use an example. So if we've got a 70-kilo male, 180 centimeters, 32, 20% body fat. Body fat's not easy to measure. DEXA body composition is probably the best gold standard version. If someone is decently lean, then we could also use skin folds, but skin folds are not very accurate on someone that's carrying more body fat. So there's not a lot of tools we can use to assess body fat, but sports physicians will often refer for DEXA body composition so we get a sense of someone's fat-free mass. So once we minus the 20% of body fat, this male has a fat-free mass of 56 kilos that we need to service adequately with energy for his bone to be healthy. So if we sort of sit in the middle of that 35 to 45 calorie range and go with 40 calories, we times his 56 kilos by 40 calories, and we get 2,240. And then that's his energy requirement, but we also have to add his exercise energy expenditure, so whatever he's done from a sport perspective or exercise perspective. So I calculate basal metabolic rate from an equation, which is just his height, weight, gender, and age, and get 1,670. And then obviously we've got daily activity. So he's not sleeping all day, he's moving around, living his life. And I give that an amount of energy. And then let's presume this guy runs 60 minutes a day, and that's his exercise or his sport. And that has an approximate energy expenditure of, let's say, 700 calories. But we do have to adjust for the fact that if he didn't run, he would still be using a certain amount of calories in that hour doing something else, or just his basal metabolic rate will be ticking over. So we minus that. So we end up with about 600 calories as the cost of his exercise. So his total daily energy expenditure, somewhere in the realm of 2,875. So what happens when this guy only eats 2,000 calories per day? So let's say for whatever reason, he is not meeting his energy requirement. He's put himself on a diet and he does his 1 hour run that day, only eating 2,000 calories. That 600 calories that was used for running is now lost to the body. It has been used, it's gone. So he only has 1,395 left from what he's eaten to service his body's requirements, but he needed 2,240 before the cost of exercise, meaning he has an energy deficiency this day of 845 calories. Now, of course, we're all incredibly smart and we know that the body is more resilient than breaking after 1 day of an energy deficit, so we don't just get bone stress in 24 hours. This is obviously a chronic outcome to low energy availability exposure. So yeah, interesting to hear also from Sam that can be, accrued over a lifetime in terms of the loading aspect of bone. And so we probably don't have great information for, how many days does it take to be in low energy availability to cause a fracture, or how chronic or how bad does the energy availability or deficit have to be in order to get a stress fracture. We certainly don't have that kind of information or data just yet. But this is really fantastic. This is a whole edition of BJSM last year with an update to our understanding of REDS and free to access. So if you haven't heard of it or seen this edition, can be a nice valuable download to get some more info around that syndrome. Something of note, though, is that adequate energy intake will never compensate for poor load management. So if someone, let's say is running 0 kilometers this week and next week they run 50K, and let's say they do increase their food intake adequately to cover the cost of the energy expenditure, that doesn't necessarily mean they're not at risk of bone stress because the bone just cannot adapt that quickly to that kind of increase in load. And I've got no expertise in load management, so I leave that to Sam and the likes. So that's energy, and I didn't want to sort of spend loads of time in that space. Like I said, it is really hard to actually calculate that with any kind of precision in daily life because people eat differently day to day. Self-report can be really poor, not intentionally, but because it just is really difficult to remember what we eat, and then difficult to describe quantity as well. I tend to not talk to clients about calories. This is something I do in the background and figure out their requirements, and then I put that into a food conversation as opposed to counting calories and things. And I'll probably allude to why that is as we go along. So our next thing to focus on will be calcium. And when we talk about bone, most people are aware that calcium is an important nutrient with bone. So don't need to spend too much time talking about how important calcium is for bone. But what are our dietary requirements? These are current, so male and female adults 19 to 50, 1,000 milligrams of calcium per day. For women at 50 years or when menopause occurs, it increases to 1,300 milligrams per day. That's because of the change in estrogen status. And with people that have compromised bone already with osteopenia or osteoporosis, the requirement is also higher at 1,300, and adolescents 12 to 18 years old who are developing bone also have a higher requirement. And men, their intake does not need to increase until they are 70, so a bit later compared to females. Practically speaking, how does someone actually reach that, and what sort of questions might we ask about diet to get a sense of that? Obviously, dairy is our best source of calcium in terms of calcium milligrams per gram of food, but also the bioavailability of that calcium to our bone and to our body. So milk, yogurt, cheese are our best sources. And I often get asked about ice cream, and that's not the best source of calcium. It does have calcium, but it's not quite the same as a milk, a yogurt, or a cheese. So you can see there that really we need probably 3 serves of dairy in our day to get close to that 1,000 milligrams. And for adolescents, women after the age of 50, men after the age of 70, or people with osteopenia or osteoporosis really need 4 serves of dairy. And I can tell you that when I do diet histories, it's really rare that someone is eating an adequate amount of calcium in their diet. I would say adolescent boys are probably the best at eating calcium, and everyone else is not very good at it. Obviously, we have some people that do not tolerate dairy for various reasons, or dairy allergies, etc. So there are alternatives. So calcium set hard tofu, the Evergreen brand in particular, is very high in calcium. Sardines. And then on this slide, I've just got a bunch of products at the moment that are sitting with higher calcium amounts per serve than seemingly kind of normal. So these can be really handy to top people up. And we actually get the fast bowlers at cricket to consume a really high calcium product prior to their bowling loads. So the Rokeby Farm smoothie, very high in calcium, the Oat Plus protein. Milo is fortified with calcium. Then these YoPro Perform yogurts have about 440 milligrams of calcium, where an equivalent size yogurt often is only around 200 in the flavored versions. And then our Tetra Pak, so things like Up and Goes, oat in a Tetra Pak, or Moo milks do have calcium, but Sustagen is the highest of all of those with 400 milligrams per serve. Then this milk on the left, the Complete Dairy, is a brand of milk that is available in Coles and Woolies, and they basically just filter it to retain more calcium per mil of milk. So 430 compared to a typical glass of milk being 272. And then Siggy's yogurt, higher in calcium than some of our other brands. And there are also now some tunas that have added calcium or more fish bone through them. So very high calcium for those. We don't obviously absorb that amount of calcium in one hit, which when you think about supplements, we do recommend separating them in the day for the absorption factor. So these, you can't just eat a tin of tuna and that's it, you've met your requirement for the day, because it's probably not going to be the best method to absorb and get to your adequate requirement. So it's just something to keep in mind. So that's calcium. I probably don't have anything else to add there, apart from it's really common that people are under consuming this food group, and I'll come back to populations at risk at the end. Sam mentioned vitamin D and the importance of screening for this with bone stress, and we'll come to who's at risk of vitamin D deficiency. But essentially, I highlighted here something really interesting where I think, important to consider that many countries have different ranges in terms of what they consider sufficient or adequate in terms of vitamin D status, and just showing here that a higher vitamin D status is allowing for more calcium absorption. So what we think might be adequate maybe isn't super optimal, and that's just something to consider. And I'll have another slide on testing bloods for vitamin D in athletes in particular further along. So diet's really a poor way to get vitamin D, because we don't have many options when it comes to food. So sunlight, incredibly important for this nutrient. But the recommended daily intakes are 5 micrograms per day, and then it goes up with age, and that's to do with the ability of the skin to synthesize vitamin D from the sun. So they hope for greater exposure through diet. But you'll see that we have limited choice. So sardines, salmon, eggs, and mushrooms. And I couldn't tell you how many people would tell me that they don't like any of those things. So really hard to get buy-in from a dietary perspective. Sometimes it's, you know, really not realistic long term to be forcing someone to eat something they really hate. So something to be mindful of when it comes to diet. We can put mushrooms in the sun and they do absorb some vitamin D, and then we can eat them, and so that can be a bit of a fun exercise if people are interested in doing that. Otherwise, in Australia, we have mandatory fortification of margarine with vitamin D. But I'm kind of detecting over the years that people are really moving away from margarine, probably based on messaging that's in the lay media, I suppose. But I don't really see that as being a common food in people's diet. So fortification of that, I'm not sure how much of an impact that's having on our vitamin D status. So this is a nice little article from Gatorade Sports Science Institute. They do a lot of good science and have good resources to do that science with. So a blood vitamin D concentration of greater than 75, but preferably over 100 seems to be a better place for athletes to sit. And I have heard from one GP that makes that recommendation, but I do think everyone sort of has a different stance on where vitamin D adequacy is or isn't. But certainly anyone with a history of stress fracture, current stress fracture, vitamin D needs to be checked, and probably don't need to tell this audience the importance of that. So who do we need to keep an eye out for, or where do we sort of need to detect some red flags? And some people can fit into a lot of these categories. So people at high risk of low energy intake are our athletes, adolescents, and our very active people. So I think it's a little bit unfortunate that we've ended up calling REDS relative energy deficiency in sport, because you don't have to be an athlete to have low energy availability. If you are a weekend warrior and you're going out for a 20K trail run on a Sunday, it's very likely that you're going to be one of the people at risk of low energy availability in the absence of being competitive in sport. So athletes, very active people, adolescents have high energy requirements by nature of who they are, and so they just might not be meeting their energy requirements. Disordered eating and eating disorders of restricted type, or purging or compensation through exercise, obviously red flags for low energy availability. And just tying back to Sam's case study, that patient did have a history of a restrictive eating disorder, which was quite severe, which she'd done really well and progressed through. And I don't think it was a regression into disordered eating that contributed to her bone stress, but rather that her education of nutrition finished with her, I guess, recovery from the eating disorder, and there was no build on that for when she took up running. And then what does your diet look like when you're running, 10Ks on a weekend? So we needed to just extend her education of nutrition and her bodily needs to get her, on track to be able to continue to do her running and to keep her future risk of bone stress low. Young athletes, so this is what I see in cricket and basketball, unfortunately. Our cricket players and our UC caps often don't come from Canberra. They move here from somewhere else, and they can be young. They can be, sometimes underage, but sometimes 18, 19, moving out of home for the first time, never cooked a meal in their life, never been to the supermarket, never earned the kind of money that they're earning as athletes, and can't budget. And so there's all sorts of things that just can lead to food that's inadequate. Sharing a kitchen, there's just so much that changes for our young athletes. Some of our sports, we need to keep an eye on these people. So weight category, aesthetics, sports, and gravitational sports. So where people might focus on their weight to make weight, so they restrict power to weight ratio, they might restrict to lose body fat, or tight uniforms, revealing uniforms, where there's an overemphasis on appearance, which might lead to restriction as well. Common one in Canberra, I don't know, this might sound rude, but we have lots of public servants that work 7-8 hours a day. So they have time to do endurance type activity on the weekends and after work or before work, or they commute by bike. So people that are increasing their load without increasing their energy intake, so they start training for a marathon or a long cycling event and just keep eating the same amount of food. So if we can flag that they need to consider their nutrition if they're taking on some new goals, that's really important. Another population I see a lot is women going through menopause, experiencing body change or a shift in where body fat is deposited, who then endeavour to lose weight and they restrict energy, and they also are not eating enough dairy. So the dairy requirements go up and they start to eat less dairy and less food overall. So putting themselves at high risk of, they might even start exercising as well, high risk of bone stress. And then obvious one, vegan diets or any version of a diet that is restricting whole food groups. People I see high risk of low calcium intake, so adolescents, just due to their high requirement of dairy, they're often just not getting there because they do need to consume more than adults, more so in girls than I see in boys. There can be a little bit of challenge around taking dairy to school and keeping it cold, and so they don't take anything to school, and then we're just relying on breakfast as being a source of dairy and maybe dinner, and that's it, which we just can't get our 4 serves if we're not taking things to school. Menopause, same reason, their requirement goes up, and I've never seen a female in her 50s that has come and knows that she needs to increase her dairy intake on account of her age or on account of menopause. That's just not knowledge that is out there. So that's one that requires a lot of shift in mentality around dairy. Dairy allergy, clearly we need alternatives for people with a dairy allergy. Lactose intolerant, the common theme here is people just don't eat dairy when they find they have a lactose intolerance, which obviously is not necessary, and we just need to find our lactose-free versions of things. Adolescents, coming back to them, with acne, I've just been hearing over the last couple of years that they've been told to reduce their dairy intake to manage acne, and I can't find any literature around diet and acne. So I'm not sure about that, but if they're going to restrict dairy, we need to find alternatives. And then misinformation about the dairy food group really just drives me up the wall, but that you can find websites that say that dairy foods are bad for your bones. So I think just sometimes correcting things like that is really valuable. And again, vegan diets, if there's no dairy, we need alternatives for calcium. And then our low vitamin D status, so indoor sports, basketball is a good example. The Caps play indoors over the Australian summer. Gymnasts who spend a lot of time inside before school and after school. Our winter athletes who don't stay in Australia for summer, so they just chase winters, they're going to be at risk. Darker skin because of the conversion of sunlight to vitamin D. Same with excess adiposity, the conversion is poorer. Older population and their skin, poorer conversion to vitamin D. And then obviously our focus on avoiding skin cancer, very important, but then we can compromise vitamin D status. Location, so Canberra and south of Canberra, not a great place to live for vitamin D. And then our vegan diets as well. So we did see that most of our sources of vitamin D through food was fish and fish. Can't remember the other one. So we can have people that fit a lot of these categories. So they can, let's say, play basketball, spend a lot of time indoors playing basketball, be an adolescent, maybe starting to show some signs of disordered eating because of concern around body image and being an adolescent. And then they've heard some weird things about the dairy food group. So we can have this perfect storm where there's multiple things that have combined to drive low energy consumption, possibly low calcium consumption as well, and then be compromising on their vitamin D status. So hopefully that gives a little bit of insight, I suppose, to what I do as a dietitian and what I go hunting for and what I take into consideration. And yeah, I guess what we can do to prevent bone stress if we're aware of people at risk, and then what we can do once someone has one to reduce their risk of a further bone stress. So yeah, we do play a key role for those that have the need to look at diet as a contributing factor. And then main things: energy, calcium, vitamin D, and then just considering the number of people that are going to be at high risk of these things and keeping an eye out and an ear out for those people. And that's it from me.
Thank you so much, Erica. We might just open the floor now to questions. There's already one in the Q&A box, but if you have any that you've been waiting to ask, please add them in now. The first question is CT a good investigation to assess navicular fracture? So Sam, I'll leave this one for you.
Yeah, so it's it's not that it's not good, it's just that the gold standard is MRI and it's preferable just because there can be the absence of that fracture line. So if I'm thinking it's in that region, I'm just going MRI straight away.
Sure, thank you. I'll give another minute or two for anyone who's got any further questions for either Sam or Erica.
I have a question for Erica.
Please go ahead, Sam.
So why do you think they did change the name to in sports instead of syndrome, or when, as you said, like it's not necessarily just the athletic population?
Yeah, as far as I know, they when they redid the consensus statement last year, they were considering having a range of endings, so in sport and then in the military, and the list could go forever. And I think I mean, I don't know, but I think potentially they'd already called it Reds, and so changing the name, and we'd already changed it from female athlete triad, and so yeah, they've stuck with it.
Yeah, I tend to still use the term female athlete triad, even though it's changed, just because people are familiar with it. But yeah, I think it's probably better to use the right terminology. Yeah.
Yeah, and with the word female, we're missing the male population. You can also have Reds. So yeah, what we call things, yeah, seemingly
Power.
but certainly that's, yeah, works with the female population for sure.
Yeah, cool.
Sam, we've got another one for you. They said, do you refer to podiatrists? They have a key role in mechanical assessment, especially foot function, load redistribution, footwear advice, etc.
Yeah, definitely. Again, like I'm a big proponent of I hope I'm good at what I think I'm good at, and then what I don't know about, I just want as much help as I can get. So definitely podiatry. You know, I might be able to give some like kind of blanket advice on particular shoe brands or something like that, but nowhere near the specificity and the specialization of a podiatrist. I tend to see a lot of patients that a foot and ankle surgeon in Canberra does, because I have a relationship with them and they have a really good podiatrist there. So yeah, absolutely. I didn't mention it much, but I would say a big part of it can be podiatry. So it's a really good question, something I forgot to put in the presentation.
Thank you. We've got another one popped up in the Q&A there, which says, are there concerns with taking too much calcium at once, greater than 600 milligrams, that it ends up calcifying blood vessels rather than strengthening bones?
Yeah, I probably can't speak to that in terms of medically. I know there is a paper around calcium supplements in postmenopausal women where there was concern around what was happening with heart function or heart outcomes. But apart from that population, I'm not sure of risk. And certainly with supplements, we need to separate them for the absorption factor. But yeah, I probably can't speak to the medical risk. I never recommend supplements, because if we're using a supplement, we're getting calcium but no extra calories, and typically we've got an energy deficit and possibly also a calcium deficit, so we're not ticking both boxes at the same time. And also we got magnesium, we got protein in dairy, it's not just calcium. So ticking heaps of boxes with food. But yeah, probably a doctor would speak better to the evidence around calcium supplement and heart risk than me. Sorry.
Thanks, Erica. We've got a few more going in the chat now. This I'll ask these two together, but open to either Erica or Sam. How quickly can these bone stress injuries occur after a sudden increase in load, and how quickly can they progress from a grade 1 to a 4?
What do you think, Erica? Do you have any great answer for that?
Absolutely not.
Neither. It's tricky. As I said, people may have no pain for a long period of time and then they progress and they're already past grade 1. Or people can have lots of pain and be grade 1. It is really a continuum and it fluctuates person to person. I guess if I'm trying to put a timeline on it after a sudden increase in load, if it's quite a big instance in load, like Erica described earlier, like we can't just eat plenty of food because we went on our 20-kilometer run, days to weeks. Where that would be on imaging, I'm not entirely sure. It's part of what's tricky about bone stress, and hopefully some of the things I chatted about, some of the things Erica chatted about, I completely forgot about podiatry, which is so important in it. There's just so many moving factors in it that it's really hard to put timelines on that type of thing. And how quickly it can progress to grade 1 to grade 4, again, I don't really have an exact timeline for it. But weeks to months, it's really tricky. I'm not really shedding too much more light on it, but just to say that there's ambiguity around it and having a high suspicion of it and being on top of it early is important.
Thank you. I think this one in the chat is for Erica. It says there was a slide where daily calorie deficit was found to be causing osteopenia. How is calorie deficit related to bone health?
Yeah, so that comes back to the energy that bone requires to remodel on a daily basis in an equal manner to its breakdown. So bone building and building and breaking down over a course of, say, 24 hours. And if we have a calorie deficit or inadequate energy, every system in the body is compromised in some way, and bone is one of them. And again, we can't say at what point that bone actually will be stressed and fracture. So how long a calorie deficit needs to continue for that to occur. But it's essentially the lack of energy for bone to regenerate appropriately day on day is why calorie deficit relates to bone health.
Thank you. This one is again for Erica. Do you ever recommend female patients with REDS see their GP to start the COCP combined pill to improve bone density?
I would always recommend when I suspect REDS that we see a GP or a sports physician because I can't diagnose it and it can be something else. So definitely always medical involvement if I'm suspecting REDS, particularly where there's symptoms such as menstrual cycle loss or irregularity. So I never want to assume it's REDS and it can be something else. In terms of the pill, not my area of expertise, apart from my understanding is that does not fix the energy deficit, and it may not fix if there's a calcium deficit or a vitamin D deficiency, etc. So all of the other things that might be contributing to that lack of menstrual cycle from a dietary perspective might be overlooked with the use of a pill, and then we're not fixing the actual driving factor if it is REDS, if it is energy deficiency. So yeah, I hope that makes sense. I think in the past that's been used and it's been deemed to be not the right management of REDS.
Thank you. I'm just going to give everyone one last minute to pop any last minute questions into either the chat or the Q&A. Okie dokie. So we are now going to wrap up for the evening. Thank you again to everybody who's attended tonight's webinar, and a big thank you to Sam and Erica for your excellent presentations and some really thought out answers to those questions at the end. Our next physio webinar is scheduled for 7 p.m. on Wednesday, the 16th of October. So please save the date. The next webinar will be covering whiplash and concussion presentations. Evaluation surveys for tonight's event will be sent out shortly, so please make sure you fill them in so that CHN can email you a certificate of attendance, and you can self-report your 1.5 hours of educational activities to your CPD home. Resources, presentation slides, and YouTube recordings will be emailed to participants who complete their evaluations. And that's all for this evening, everybody. I hope everyone has a good night.